and welcome everybody to this session today, to this research seminar, which is brought to you by the West Midlands Social Work Teaching Partnership. My name is Deb Stewart. I'm a consultant social worker for the West Midlands Social Work Teaching Partnership. So we are one of 28 accredited teaching partnerships in the country, and we bring together academics, practitioners, senior leaders and experts by experience to strengthen the quality of social work education, training and practice across the region. So we've got 27 partners in total, including higher education institutions, children's trusts, local authorities and NHS trusts as well. So one of the areas we've been working on is improving social workers' access to and understanding of research and supporting them to apply messages from research to practice. And one way that we hope to do this is via the seminars, of which this is the third one, and they've been popular and well received as well. So just to start us off today, I'd like to introduce Jo Mccormack, who's from NICE, and she's going to just do a short presentation about NICE's role in safeguarding research and practice. So over to you, Jo. I think we might possibly have just lost Jo. We'll just give a second to see if she, oh yeah, here we go, she's come back. Sorry, just bear with us, guys. Hi, Jo, are you there?
I am. Cool, we were all ready. Let's laid plans and all. Sorry about that. As soon as I went to share, it made me leave the meeting. But I'm just going to, hopefully everybody can see that now. That's brilliant. Thanks for bearing with me, everyone. My name's Jo Mccormack. I'm part of the field team at NICE, the National Institute for Health and Care Excellence. And I'm just grabbing just a couple of minutes at the start of today, just really to set the scene about how valuable evidence is to NICE and particularly that research evidence. So NICE sits under the Department of Health and Social Care. It's a government-funded public body. It's responsible for providing that evidence-based guidance for health and social care. It's about improving that quality, safety, equity of care, ensuring that there's better outcomes for the people who are using those services. And our aim is really to put that evidence at the heart of health and care decision making. So when NICE is asked to put together guidance on a topic, there's a robust process that it follows that includes putting together a committee of independent experts, lay people, service users and frontline staff, and they meet several times over the course of a guideline development, and the committee reviews all the available evidence on a topic. And it looks not only at effectiveness but extent of uncertainty, social values, ethics, equity and rights, the practicalities of implementation and cost effectiveness. So having reviewed all the available evidence, NICE publishes these recommendations on what's safe, effective and cost effective practice across health, public health and social care. Where NICE would like to say something but there's a gap in the evidence, it will often make recommendations for research, highlighting the research question and the rationale. And you can view all our recommendations and those for research on our website. They're all on a guideline landing page specific for that topic.
Sorry, Jo, just to let you know, we can't see the slide presentation. We can just sort of see your PowerPoint. We can see the first slide at the moment. I'm not sure if that's the one that you're on.
Oh gosh, no, I've moved on quite a bit. Of all the times actually to run into some difficulty with that. Let me see if I can stop sharing a moment.
I think you just need to share the presentation, the slideshow. That was it. Just try again. Thank you. That's it, Jo. Thank you.
Everybody's got it now. Sorry about that. There is a copy of the slides that will come out to everybody, but I did just want to show people this is NICE is always very consistent. This is a typical guideline landing page. We've only got one where we've got safeguarding in the title, and we did happen to publish it just last year, so it's still relatively quite new for NICE. It's safeguarding adults in care homes, and as a sort of typical guideline, you can click on that left-hand side and you will be able to pull up all the recommendations we make. Everything that's based on all the evidence, all of those evidence-based recommendations. You have got recommendations for research you can also click on, and there's always tools and resources that accompany to try and help with implementation of any of that. So we do have resources available on the website that might be of interest. Deborah, can I just check that the slide set has moved on?
Yes, it has, yeah.
Oh, that's brilliant, excellent. So I just wanted to say for social workers, we have a section on the website on using NICE guidance in social work. It does include some example scenarios. There's examples by setting and also some for principal social workers. And then since our recommendations and particularly in our guidelines can be very long, we do have something called quick guides. I've just shown a couple on the right hand side there. They are visual summaries. They're an A4 sheet just pulling out the key points on our guidance on a particular topic. There's about 20 in the range and we've got a couple very specific ones on safeguarding there. So very much the evidence is vital to NICE's work. We review that, we put that into our recommendations. That's part of national guidance, and we have some tools and resources such as the quick guides to try and make that easy for people. That's lovely. Thank you.
Thank you, Jo. As always, it's really informative, and it's great to have those links as well for people to go and check that out. So thank you so much for joining us. Thank you. Right, so I'm going to hand over now to Laura Pritchard-Jones, who's leading our research seminar today. So Laura's from one of our partner organisations, Kira University, and she's coming to speak to us about the messages from her research regarding COVID-19 and adult safeguarding. So I'm going to hand over to you, Laura. Thanks for being with us.
Good morning. Thanks very much, Deborah, and thanks everyone for, well, first of all, thanks for the invitation, and thanks everyone for turning up. I hope you find it quite interesting what I'm going to be talking about this morning. So if I get my slides up, I'll probably be dipping in and out of my slides. Just bear with me. Again. It just might take a couple of seconds to load. So just while they're loading, just by way of background, in early 2020, when we obviously when you know we knew about the pandemic and it was March, we went into the first lockdown. We decided to look at, following some conversations, and I've got a couple of slides in a little while that I'll talk to you a little bit more about the rationale for this project. But having conversations with a lot of the practitioners that we teach and that we work with, we decided to put a project together looking at the impact of COVID-19 on adult safeguarding. Huge apologies for the dog barking in the background, by the way. After 2.5 years of working from home and teaching from home, I'm immune to it now. But yeah, I forgot to apologise at the beginning in case you barked. So we decided to put a project looking more in detail, in particular the practitioner perspective of adult safeguarding during COVID. So basically part of what I'm going to talk to you about today are the findings from that research, and it was quite a wide-ranging project. We had a lot of findings on a lot of different topics and a lot of different themes, but there's 3 in particular that I want to sort of focus on. But just by way of background to the project, I always start with any discussion or any presentation that I do on this particular project with 3 sets of acknowledgements. So the first, obviously, we were very generously funded by the Health Foundation, and we couldn't have done the project without their financial support. So huge thanks to the Health Foundation. Second is to obviously thank the participants in the research as well, because again, without those, I wouldn't have anything to talk to you about today. And lastly, to all those that supported in dissemination and recruitment. So we were widely supported across adult safeguarding nationally about the sector, and we had a fantastic steering committee that helped us in terms of framing the project. So first of all, those 3 thanks need to go out to all those individuals. So before I talk to you a little bit about the actual research project, what I want to ask really, just generally to get everyone a little bit warmed up this Tuesday morning, and again, understanding that you might work from a range of different backgrounds, so you might work predominantly in adult social work or adult social care, or you might be involved more in children and family social work. What I want to get is really what has been your experience of safeguarding during the pandemic. What's your understanding of safeguarding generally? And how has this maybe changed over the course of the pandemic? What changes might you have found to your role? What challenges might you have faced as a result of the pandemic and some of the changes that the pandemic's brought about? So just opening it up, first of all, to questions or comments or points or thoughts in relation to these particular questions. Does anyone have anything that they want to offer by way of thoughts? Okay, great. We've got some hands up. So should we come to David? We'll come to David White first.
Yeah, I'm practice manager adult social care. I think during the pandemic, one of the real challenges was actually getting into people's houses, because you can't really do safeguarding on the doorstep, but people were not comfortable with you going into their homes during the pandemic, and we had 2 or 3 safeguardings that were very difficult to explore because we couldn't get past the doorstep. Thankfully, that's starting to be easier now, and we are getting into people's houses, but it's very difficult to argue with somebody that you've got to go in their house when government advice is not to.
Yeah, absolutely. And interestingly, that again was one of the dominant themes when we did our research, was actually some of that challenges. Safeguarding in many ways depends as much as also what you see is what you have, those conversations that you have, and actually that's a big part of adult safeguarding. And how do you do that? How do you navigate that when there might be physical barriers to you actually intervening in or entering a person's premises, and also the guidance itself might say actually we recommend that you don't go in or you don't do face-to-face visits. Yeah, absolutely. Lucy.
Hi. I am advanced social work practitioner in community hospitals team in Worcestershire, and I got that job only a couple of weeks before COVID started, but I was in the hospitals team before that. But what we found was, and what I found, we had a humongous rise in safeguarding. We were picking up in hospitals, and I guess that goes in hand with the person we spoke to, because obviously when somebody was coming into hospital, we were then picking them up. But also I think, and I commented several times through the whole experience in supervision and with the rest of my team, is we were getting a lot more people in that self-neglect area. And often I think people who were overlooked or weren't engaging previously often would fall through the cracks. And I can't tell you the amount of people that came into hospital and we took on and dealt with the safeguarding through that entire year and a half. And I think it's kept going since then. We certainly have, we've got 3 or 4 people with a safeguarding referral in at the moment, and that is very unusual, because prior to COVID I think we would probably get in the community hospitals, not the acute hospitals, I don't know, maybe 2 every few months, and that's it. But we can get that in a week at the moment, so it's really absolutely.
And interestingly, one of the things that we asked, I'll tell you a little bit about the methods later, one of the things that we asked were, were practitioners seeing different rates or different types of abuse or different scenarios basically coming to their attention? And one of the things that was almost universally reported was situations being much more complex than they might have been beforehand, or, having had that ongoing contact with the person. There was a huge concern over hidden forms of abuse and neglect, of which, a lot of practitioners raise self-neglect. Domestic violence, financial abuse, all these ones that are difficult enough really to detect and respond to start with.
Yeah, we've had several domestic abuse and several financial abuse come through, and physical abuse suspected. So yeah, we definitely concur with that from the hospitals. So yeah,
fab. Anybody else have any reflections or any thoughts of what their experience has been during the pandemic of safeguarding? Okay, well, I think that sets us up anyway for the following few slides, where I'm sort of going to introduce you a little bit to some of these findings of the research. But before I really get to that, I obviously want to explain a little bit about the study and a bit of the rationale behind it. So by way of background, just so you know a little bit about me, I'm actually a lecturer in the School of Law at Keele University. So unsurprisingly, my background is very much in and around adult safeguarding and mental capacity law and policy. And one of the things that I'm responsible for is I do teach some on the social work programme at Keele, but also predominantly on the MA in safeguarding adults. And I tend to do a lot of conferences aimed at practitioners and a lot of research findings aimed at practitioners. So local safeguarding boards, do talks with practitioner forums, things like that. And one of the things that we're having in particular were conversations early on in the pandemic, certainly in March 2020, and then into sort of April and May, were one of the things that we're having were conversations around some of the informal and anecdotal concerns that practitioners had around adult safeguarding, but also, exactly as Lucy was just saying, increases in certain types of abuse, and things like domestic violence and self-neglect and financial abuse were often raised. And I think this goes hand in hand also with some of the concerns that we sort of saw also in the national media as well around the impact of lockdowns in particular. But lockdowns as well, for those in those conversations that we were having, was presenting particular concerns and challenges when it came to safeguarding, for example, in care homes. But we also very early on saw through the Coronavirus Act changes to some facets of adult social care law more generally. Now, the legal obligations in terms of adult safeguarding didn't change under the Care Act under Section 42. But we did have what were called easements, where local authorities could elect to enter into a level of easements. The higher two, in particular, were notifiable to the Department of Health and Social Care, but the lower two really allowed for a degree of flexibility and flexing, so that the local authorities could manage the competing pressures that they were facing during the pandemic. So as a result of all of these conversations, these sort of informal chats and conversations that we were having, we decided that actually what we needed was a much better systematic understanding of some of the challenges and the changes prompted by COVID, particularly through the eyes of practitioners, because we really thought that actually in terms of adult safeguarding in particular, you don't see it as often at the centre of a research project by itself. And so you don't necessarily just see practitioners involved in adult safeguarding at the centre of research projects. So that's what we really wanted to encapsulate with this research. So in terms of our broad aim, we really wanted to investigate the impact of COVID on adult safeguarding and also social care law and practice, because we can't divide the two. You know, on one view of things, local authorities have responsibility for the safeguarding inquiries, or they can delegate them. Local authorities have responsibility for the safeguarding inquiry, so it sits within a local authority function. But also it's inextricably linked in many ways to social care provision. And how changes that the practitioners might have faced have impacted their ability, or the feeling that they had about their ability to safeguard adults at risk of abuse and neglect. So this was the overarching aim, the really broad aim that we went into this project with. So we had a number of different areas of inquiry, and unsurprisingly, one of the key areas being that we came, in terms of our backgrounds, we came from predominantly legal backgrounds, was first and foremost the impact of COVID-19 on the law in adult social care and safeguarding in particular. And then beyond that, more of a socio-legal inquiry, which was understanding more about putting the law into practice in order to safeguard adults and understand adult safeguarding during the pandemic. So that's what we started out with, wanting to understand more about things like the Care Act and the Mental Capacity Act, which are understandably two of the most commonly talked about, and were two of the most commonly talked about in our surveys and interviews. And then understanding more about the impact of COVID-19 on broader adult safeguarding practice, and generally speaking, how practitioners felt that their ability to safeguard had been impacted by the pandemic and some of the changes that the pandemic had prompted. And importantly, one of the things that we wanted to do was to identify strengths and strategies that practitioners have drawn on. It was an unprecedented time in many ways, particularly in the early days of the pandemic. And so what we wanted to look at more is those sources of resilience, or the ways that practitioners have navigated and coped with some of the changes and the challenges that the pandemic had presented, with a view to learning more really longer term about how practice might change in this area. And unsurprisingly, one of the key themes, as we'll see a bit later on, was around the use of technology. And there were certainly mixed feelings about the use of technology, depending on whether the participants were what they would class as frontline practitioners or non-frontline practitioners. And again, I'll talk to you a little bit more about that later on. So in terms of being a research project, we obviously entered into it following our conversations and the steering group and the meetings with the steering group. We entered into this research with hypotheses. So we thought that technological and virtual working would have come out as a dominant theme, and indeed that proved to be correct. And we felt that based on the conversations, the hypothesis that we put forward was that technological and virtual working would be broadly welcomed but present challenges in terms of frontline practice. And again, that tended to be a hypothesis that was correlated or that was proved by the research, the findings from the research. We also thought that particular areas of concern would emerge, so organisational settings in particular, so care homes, nursing homes, settings like that there would be particular concerns of self-neglect and domestic violence. So these more hidden or already difficult to detect types of abuse and neglect might have presented, or there might have been greater challenges presented by the pandemic. And also some of the challenges implementing the legal framework, in particular some of the ethos underpinning the Mental Capacity Act in terms of participation. And so these were generally our hypothesis, and they were based, like I say, on those conversations that we're having informally and as with the steering group, but also they're informed by our understanding of the existing issues pre-pandemic. So things like legal literacy, for example, and some of those challenges implementing the legal framework are often reported in Safeguarding Adults reviews and also in the national analyses of Safeguarding Adults reviews as being a big area. So these were also informed by our existing knowledge of the research around adult safeguarding. So in terms of the methods, obviously we did undertake and we kept up to date with an extensive review of the literature, some of the statistical data that was coming out, for example, from the Office for National Statistics. There was also a large project undertaken by ADAS and the LGA, the Insight project. I'm not sure if you're familiar with it, but that was looking specifically, it was almost like a temperature check every so often of adult safeguarding concerns and adult safeguarding inquiries. That was undertaken by ADAS and the LGA. And I think they've published three of their reports. So obviously we kept up to date with what that sort of data that was going on a regular basis was saying as well. And also some of the broader qualitative research that has started to emerge more lately, because obviously it takes time to do the research and to get it published. But there was some earlier stuff in particular with guidance and shorter pieces of research around things like technological working. Health Watch, for example, published various things on digital assessments in the health sector. So we obviously, this is framed, and our understanding of our research project is also framed by what's been said in the existing literature. So in terms of the substantive research, the sort of the qualitative research that we did a survey of frontline practitioners, and so these would be frontline practitioners with responsibility for things like mental capacity assessments or Care Act inquiries or needs assessments, things like that. This was disseminated as the call for participants through for all the research was disseminated through our network. So we're very lucky to be in a position where we've got networks in the School of Law with local authorities and Safeguarding Adult Schools and NHS trusts across the country. So we disseminated that as widely as we possibly could. And we also undertook some semi-structured interviews with either frontline or non-frontline practitioners. I'll talk to you a little bit more as to what I mean by frontline or non-frontline for the purposes of this research. And these took place across practitioners that came from 20 different organisations. So we've got a pretty good representation of organisations, and they came from a variety of different backgrounds. So some from social work, some from nursing, some from Safeguarding Adults Boards. We also undertook some comparative freedom of information requests, looking at things like needs assessments, carers assessments, capacity assessments, etc., between 2019 and 2020. But by and large, I'm putting that in there for completeness, but I'm not going to talk to you about the results of the freedom of information requests really today. There were some interesting findings, in particular, almost universally across local authorities, carers assessment numbers went down. But in terms of adult safeguarding, I want to talk to you a little bit more of the substantive findings from the surveys and the interviews. So, we asked survey respondents to identify their professional background, so which type of employer they worked with, and we obviously also asked about whether they had responsibility for things like mental capacity assessments, care assessments, were they also best interest assessors. And as you can see, the majority of the participants came from local authority backgrounds. A smaller number came from the NHS trust setting, and some came from other sectors such as charitable organisations, the private sectors, and one indicated that they came from another kind of employer. And in terms of interview participants, I should also, just going back to the survey responses actually, I should say that all of them identified that they had responsibility for things like mental capacity assessments or care act assessments, for example. In terms of the interview participants then, the split here was evenly between those that classed themselves as predominantly frontline or those that classed themselves as predominantly non-frontline or hybrid. So in terms of predominantly frontline, those that are in blue on this pie chart, we were talking about professionals that came from social work, from nursing, or had another kind of support work role within adult safeguarding generally. In terms of those who identified themselves as predominantly non-frontline or hybrid, and I say hybrid because, for example, there might have been those with managerial responsibility, but might also undertake some of the more complex inquiries, safeguarding inquiries that come in. So although their main day-to-day job was non-frontline, it might be more managerial or organisational. Actually, they still undertook or still had some role in adult safeguarding on a frontline perspective. They might still do capacity assessments, they might still go out and do safeguarding inquiries. But by and large, generally speaking, those from a non-front line, and this is one of the reasons why we opened up interviews, because we know from what we know about adult safeguarding, we know adult safeguarding is said, LGA talks about it as everybody's responsibility. So we also wanted to capture the non-front line and the strategic perspective. So again, participants from that role tended to come from either managerial role in safeguarding or social care, a strategic role, so they might have strategic responsibility for the direction of adult safeguarding more broadly within a geographical area, or they might have come from a safeguarding adults board, either in terms of management or chairing a safeguarding adults board. So that's just a little bit in terms of our overview and the background to the project and the methods. And the first thing that I want to really start by talking through the findings about is by contextualising the findings by saying that while some of our research did identify that COVID there were particular challenges associated with COVID. One that was often reported was an increase in safeguarding inquiries coming in, or an increase in safeguarding referrals coming in around infection control in nursing homes or care homes, for example, and in particular the transmission of COVID in care homes. And obviously that has been recently the subject of a decision by the High Court in terms of the government policy in discharging patients untested or potentially asymptomatic patients back to care homes. So COVID had, in terms of our research findings, COVID had presented very particular challenges. So it had raised challenges that would not perhaps have otherwise come about other than because of COVID. But what was by far the stronger message that really came through from our research, from the findings, was what COVID had told us about adult safeguarding beyond or across the pandemic. So in particular, the fact that one of the strongest messages that came through was the fact that COVID had presented some of these new challenges, but also exacerbated a lot of the current challenges or the existing challenges in adult social care and adult safeguarding in particular that had existed before COVID came along. So a lot of the conversations that we had were not narrowly about COVID. It had presented some challenges, yeah, absolutely, but these were linked to some of the broader challenges that practitioners faced really in their day-to-day jobs. And this was particularly strong for frontline practitioners, but also those from a non-frontline perspective reflected very often on the exacerbating effect that COVID had on adult safeguarding from a strategic perspective and also on a national level, and some of the issues in particular facing adult social care. So because we had so much material from the surveys and many of the survey responses were very in-depth and lengthy, but also the interviews were as well. So although we aimed for 1 to 2 hour interviews, actually many of our interviews went over 2 hours. I think the longest was about 2 hours and 45 minutes. So we had to analyse the results using some sort of framework or axis for analysis. And so we identified it broadly in line with some of the questions that we'd asked as part of the survey and the interviews. So first of all, changes and challenges. So what were the predominant themes underpinning changes and challenges that practitioners had faced? What were the impact? How did practitioners reflect on the impact of the pandemic? And also, lastly, the adaptations and the strategies. So what have they done to cope with some of those changes, challenges, and the impact that the pandemic had? And you can see that we had a really broad range of findings from the research. And there's 3 or 4 that I'm going to talk to you in particular about today, but this was just to give you an overview of the different findings. So first of all, one of the key challenges, particularly for practitioners, was consistency in implementing legal frameworks. And that's going to be one of the ones that I'm going to talk to you in more detail about later on, so I'm not going to tell you or elaborate on that anymore on this slide. Relationships across other agencies, this was also a dominant theme in terms of the changes. And what practitioners felt, generally speaking, was that COVID had presented some really positive opportunities for working closely with other agencies. And obviously, you know that adult safeguarding is an interagency effort or multi-agency effort. It very infrequently does it fall just with one agency in terms of adult safeguarding. So what we found was that the pandemic presented opportunities for strengthening those relationships. Particularly, that was driven by the shift to remote working and the use of Teams, the use of Zoom and things like that to arrange multi-agency meetings, for example. This is also the case among non-frontline or those that classified themselves as from a more hybrid role, but it had driven, again, closer interagency or multi-agency working. But there were some challenges. There did exist some challenges, or COVID had presented some challenges also in terms of building relationships and maintaining relationships across agencies. Again, there's broader findings about this research available, and I'll put the link in later on to our full webinar. So we ran a full webinar in November looking at the findings of all of these particular areas in more detail. So I'll post you a link to that later on. In terms of the day-to-day changes, unsurprisingly, there were a lot of day-to-day changes recorded by practitioners who took part. So in particular, things like the shift to home working, and that was a big shift for many, and that had been seen as a positive, certainly from an administrative perspective, and also in terms of a cost-saving perspective for those that worked in non-frontline roles. Information, again, that was a big source of that was a big theme that emerged from the research, in particular in a variety of different ways. So practitioners often reflected as to how they could get information. This is something that was mentioned at the very beginning when I opened it for questions. You know, how do you get information? How do you source information? How reliable is that information if the fundamental way that you do your job on a daily basis is changed as a result of the pandemic? But also there were concerns about information that was coming down on a national level as well. And one of the biggest challenges, I think, for practitioners navigating the pandemic and working adult safeguarding and social care generally was the information that was coming down in terms of changing, and the fact that it was changing on a daily basis. And I think at one point one participant called it relentless. So there were challenges around information gathering from a safeguarding perspective, but also there was challenges navigating the information that's part of the day-to-day role in this particular area of practice. And then lastly, some of those ethical questions that underpin adult safeguarding. So, you know, balancing a person's autonomy with protection, trust, that was a big feature as well in terms of how do we build trusting relationships with individuals that we might be supporting through adult safeguarding if the way that we would normally make contact with an individual has changed, if we have no option but to have recourse to the phone, for example. How do you effectively build those trusting relationships? In terms of impact then, unsurprisingly, types or contexts for abuse and neglect have changed. So practitioners generally said that they felt more concerned about those that might be classed as hidden forms of abuse, and things that came up again quite often in the surveys and the interviews with self-neglect, financial abuse, domestic violence, care and abuse, or neglect and abuse in care homes or organisational settings. But also so one of the things that we did as part of our survey was we asked this question, so whether practitioners had seen changes in the types of abuse and neglect that they were seeing in terms of safeguarding referrals or concerns or inquiries. But we didn't align it to any of the existing categories of abuse and neglect, either in the care and support statutory guidance or those that are returned as part of the Safeguarding Adults collection statistics. So we allowed practitioners really to identify their own categories. And quite often, obviously, they reported self-neglect, but also an increase in mental health and a deterioration in people's mental health. So those clients or service users that they were supporting, they reported more often a deterioration in mental health. A second impact, which was a really interesting one for us because we didn't go into it with this as any sort of hypothesis, is perception of practice, particularly for social workers. And again, that's going to be one that I'm going to talk to you a little bit more later on, so I'm not going to talk to you in any detail about it here. There were also concerns linked to the challenges implementing legal frameworks around the impact that the pandemic had on people's legal rights. And again, I'm going to talk to you a little bit about that in a couple of slides' time when we talk about the legal framework, so I'm not going to discuss that in any length here. And unsurprisingly, there were quite significant emotional impacts on practitioners as well, and these were generally very, very negative. So, you know, frustration, anxiety that they might be missing something. Interestingly, anxiety around potentially catching COVID wasn't a dominant theme at all. What was much more dominant was anxiety linked to maybe missing something as part of their safeguarding role, or, you know, when a referral about abuse and neglect comes in, possibly missing something or not seeing something. That was the biggest source of anxiety or driver behind a practitioner's anxiety in this particular research project. And then workloads and complexities, again, very often practitioners reported increased workloads, but also really increased complexity of situations that were coming forward as safeguarding referrals. And then lastly, onto the adaptations and the strategies. So creativity. So practitioners often reported that they had to be creative in the way that they went about their duties and their obligations during COVID. They had to find different ways of gathering information. They had to find different ways of sourcing information to undertake or to feel like they were getting anywhere near really fulfilling their role. Adjusting to technology, of course, and there were some very interesting reflections on the things that mechanisms that practitioners have put in place to adjust to this use of technology. And also developing and increasing skills around communication, in particular information management and things like that. And then lastly, working environment. So this wasn't necessarily an adaptation or a strategy, but it was more a reflection on what worked behind a practitioner, where a practitioner was reported as feeling that they'd been well supported. That was often because of the broader working environment, one that fostered professional curiosity a little bit more and allowed practitioners almost that sort of free rein to pursue a particular line of inquiry or pursue a particular avenue. So just to talk to you a little bit about the implementing legal frameworks findings then, unsurprisingly, a large part of this focused on implementing the Mental Capacity Act. And almost all the practitioners that we spoke to, the frontline practitioners, but also some of those in a non-frontline role who might have taken on some of that work during the pandemic, or might see or work with some of the more complex situations that arise. One of the main areas of discussion was around the Mental Capacity Act and the impact that the pandemic had on properly and fully implementing the MCA. Now, first of all, there have been issues around guidance about the Mental Capacity Act in particular, and guidance that came down on a national level. But beyond that, some of the most often reported questions or concerns was this third bullet point, which was the remote means of assessing, in particular video calls or telephone calls, for most practitioners. And I say most because I'll talk to you about the fact that there were pockets of areas where actually remote means of assessing did work for capacity assessment. But remote means of assessing, particularly in situations where there might be concerns about abuse and neglect, seem to go for many practitioners against some of those fundamental principles under the Mental Capacity Act. Some of those principles contained in Section 1. So, you know, a person is not to be deemed to lack capacity simply because they make an unwise decision, these types. A person is not to be deemed to lack capacity unless all practical steps have been taken to support them to make a decision, that one in particular. And so the concerns that came out really was, first of all, how can an individual properly be involved in a remote assessment, and particularly where there were certain types of disabilities or impairments. So, for example, dementia. This was as an area of concern for practitioners as to whether they were really fully getting the picture, whether they were fully allowing that person to contribute to the capacity assessment, where it was being done virtually or remotely. But also assessing a person's executional capacity. So particularly the literature around self-neglect, for example, talks about the fact that capacity isn't just about making the decision, it's also about being able to put that decision into practice. So can the person might be able to understand what process goes into making that decision, but they might not necessarily then be able to follow that through. And I know that if any of you have ever listened to Michael Preston's Shoot Talk, for example, in his work and his and Susie Bray's work around self-neglect, they give the example of you can go and sit down and talk to someone about what are the steps involved in making a cup of tea. But then if you ask them to show you how they might put that into practice and show you how they make a cup of tea, they might struggle. And that latter part is what they term executional capacity, actually executing that decision, putting it into practice. And so one of the things in particular that came through from the reflections of practitioners in the research was these sorts of virtual ways of conducting capacity assessments, or remote ways, whether it's on WhatsApp or on the telephone, or on a virtual way, on Teams, on Zoom, or something like that, Skype. It was very hard then to properly assess a person's executional capacity. So you can still talk to them to some extent about the actual decision-making processes that go into making that decision, but actually getting them to do that and to show you how they might make a cup of tea, to use Michael Preston-Shute and Susie Bray's example, was much harder, nigh on impossible in some situations. And so there were some real concerns as to the extent or the impact that this might have had for practitioners on the quality of the capacity assessments, but also the impact and the challenges around the concerns that this might have had on people's legal rights and their ability to challenge decisions. And one thing that was often reported was whether people may have been discharged into a care home, finding or following a capacity assessment, where it's found that they lack capacity, and then actually perhaps are we going to see later on instances of this coming to light where actually they'd had capacity to make that decision all along. Another area that came up very often in discussion was around mental capacity and its relationship to discharge from hospital. And discharge to assess in particular came up as quite a strong area of discussion, and concerns around the D2A model generally, but also specifically during the pandemic, when responsibility for capacity assessments, for example, might have changed. And one of the concerns is summarised really by this quote, was that legally practitioners, some practitioners felt that they were on very rocky ground, because if a capacity assessment around care has to explore a person's understanding of relevant information, one of which is what the options in respect of that care are on the table if they're discharged back into the community, then how can those in a hospital setting assess that? Because it's not the hospital that has responsibility for devising those different packages or those different care plans. So they felt in a little bit of a sort of a difficult position, because the capacity assessment responsibility might have shifted to them in hospital because the changes to visiting and regulations around, or difficulties in terms of not being able to visit, social workers not being able to visit and whatnot, and not being able to go onto the ward, understandably because of obviously COVID and the fact that a lot of the wards had closed because of COVID. But how can ward staff effectively assess a person's capacity to make that decision? So because they don't have responsibility for putting those care plans in place or setting up those options. It's the local authority that would have an understanding of what that was. So there were certainly some concerns around discharge and discharge to assess, but also discharge obviously more generally from hospitals. And in particular, these concerns generally fell into concerns that the person's wishes and feelings were not fully taken into consideration, thereby really not upholding the MCA in the extent that it could be, or the underpinning the ethos, basically not upholding the ethos that really underpins the MCA. That shift in responsibility for capacity assessments, and that was a concern shared across both those that came from a social work perspective and those that came from a nursing perspective. We did have practitioners who took part in this that were adult safeguarding nurses, and that was a concern for those that came from a nursing perspective as well. And also more limited opportunities generally for maximising the support for a person to make a decision, again seeming for practitioners to go against those principles in Section 1 of the Mental Capacity Act. So whereas practitioners might have previously, before the pandemic, visited multiple times, different times of day to maximise a person's decision making, that wasn't possible during the pandemic. So as I say, there were some general concerns and more specific concerns around mental capacity and the impact of the pandemic on really upholding the Mental Capacity Act and promoting best practice around the Mental Capacity Act. And this, unsurprisingly, also led to concern about the impact on people's legal rights and those rights under the MCA. And this is one of the quotes in particular that summarises that. So I think that ultimately we'll find that people have been deemed not to have the capacity when they have, or have returned to capacity. And they've perhaps sat there, this particular respondent was talking about in the context of discharge to a care home, and before their next DOLS review, when they've had capacity, and they've probably been objecting, but nobody's listened to them. I think there will be a lot of concern around that in the future. And we know that there are perennial issues with DOLS. This is one of the reasons why they're being replaced with the liberty protection safeguards, if and when they ever come in. We're finding that lots of people placed in care settings by trusts in February 2020 to clear hospitals. But when we've seen people to do the DOLS reviews or authorisations, it's clear that people have the capacity and didn't consent to the placement. And so I think that ensuring that capacity has resulted, capacity in hospitals has resulted in breaching people's rights. So again, this is a concern that was shared among a number of, these are just a couple of quotes. And so I suppose one of the messages from this research is really monitoring the longer term impact of the pandemic. So one of the things that we always try and do at the end of any research project is think about the way forward. What can this tell us about the future for research, not just about the future for practice? And so one of the things that I think we need to be attuned to and alert to is the longer term impact of the pandemic. And you know, whether these concerns do come to fruition. We'll only know that over time, I suppose. So because it's not just me, or don't want it to just be me talking at you all morning, yeah, Melanie.
All three of us really missed the beginning, but luckily the question helped going into the comments. But we were just talking around various things about the law that we're using. So obviously the Care Act, Mental Capacity Act, Human Rights Act, Mental Health, the Mental Health Act, but also around our understanding and the experiences that we've had, especially because the teams have changed a lot over the last 2 years. We've had a lot of new members of staff, a lot of very fantastic unqualified staff as well, who are also carrying out mental capacity assessments and assessments under the Care Act, and about how we've been trying to incorporate the law into our training and understanding ourselves as a group. So whilst we get our mandatory training, which is great, we've also all been looking at different ways of trying to increase our knowledge by using different methods. I was just saying that we've recently completed some mental capacity training, which is going to be, we're going to roll out through the authority, which is just literally an hour and a half's worth of looking at lots of things, including executive functioning and things like that. So that's been really beneficial. We had a newly qualified social worker on the team who probably hasn't had the luxury of having the experience that she would have had if we had been in the office. So those conversations that we'd usually have in the office around discussing cases and, you know, talking about situations with our peers, we haven't had as much. So that's been something that, you know, has been difficult over the last couple of years.
Yeah, absolutely. And interesting that you ended that point, Melanie, because one of the findings again that we had was this concern about the lack of informal information and informal information gathering because of the shift to more sort of working from home and things like that. And those sorts of shifts prompt almost like a loss of that ability to get that informal information. You know, that loss of ability to just have that sort of conversation with someone sat across the office from you about a particular person or a particular client. So yeah, thank you for that. Claire.
I was just wanting to sort of follow up on that point, really. I work predominantly with social work students, you know, and we had to completely redevise all our induction training to do via Teams, but, you know, they were doing placements from their own, you know, from a family home with other people living in it, or from a student room where they were doing all their assignments and living, and, you know, and just not picking things up from those informal conversations. Far less shadowing as well. Workers were very reluctant to offer remote shadowing. I kept saying, this is how you do a conference call, or you could connect with them via Teams and they could put your phone on speaker, but the very few offers of that. So really hard for students to be learning about stuff. Getting better now that people are going out again. but you know, well, my local authority have discovered new ways of working and realised we don't need all the buildings, so we'll never go back to the same way we were. So there are potential long-term implications for learning. And in terms of the law, it's about new people coming in and how do they pick up from others that the implementation and that practitioner knowledge, and it could be interesting research topic for the future in terms of how has that affected the quality of people who are now qualifying, who've done all their training during the pandemic.
Yeah, absolutely. And that importance of that workplace where people who are coming into it as new members of staff or as newly qualified, where they pick up those aspects that inform their practice moving forward, you know, from more experienced colleagues. And there's been, we say it in higher education, so in university, we're seeing students that are coming in now to first and second year that have had a very disrupted A-level experience. And so they're coming in with perhaps a different level of knowledge that students who might have started their degree 2 years ago are coming in with. And it's the same sort of principle in practice. And interestingly, one of the things that we want to do, I'll get the slides back up now actually, because I'll talk to you a little bit about the just sort of the adaptations and the good practice and things like that. One of the areas that we looked at in particular was learning about the role of technology, and should be coming up now. So one of the questions was, well, what role does technology have in this particular area of practice moving forward? And yes, absolutely, it was very strong that working from home and using that way of working was great in terms of interagency working, getting different agencies together around a table. But actually, in terms of social work as a profession, because the majority of people that we had participating came from social work backgrounds or were frontline social workers, for example, there was a very strong sense that actually as a profession, it really shouldn't go down the virtual way of working. So I'm just going to go through now to the last couple of slides. So in terms of the next bit really was just to talk to you a little bit more. One of the areas that we weren't expecting to get up as a theme or as a finding was in terms of perceptions of practice, and this was a dominant theme in particular from those that took part from social work backgrounds. And what we found was that it existed, or their perceptions of their practice existed on a spectrum really, from something that was quite negative, and the pandemic had quite a negative impact on them and led them to feel more de-skilled and reactive, or that social work, for example, was missing an identity compared to, say, health. And again, one of the reflections that often came through from our research was about the messaging, the national messaging in particular around protecting the NHS and things like that. And actually, there was a feeling that perhaps social work has its identity missing compared to if you're a nurse or if you work in the medical profession. And I put just a couple of quotes here on this slide, quotes from participants in the interviews to really elaborate on these different points. But then on the other end of the spectrum, in terms of perceptions of practice, COVID really presented an opportunity to stop people from stagnating in their professional backgrounds. And this was linked in particular to things like with a renewed focus in care homes on infection control and cleanliness and things like that, that had perhaps made them see things that they might not have seen pre-pandemic. So where they might have just put something down to a little bit of, or a little bit of dirtiness or, a bit of lack of cleanliness, actually, because the renewed focus on the need to minimise transmission of COVID and the need to wear PPE and things like that, actually, it's probably made them think about things in a care home in particular in a different way than they might have done previously. But also the shift for some to remote working had helped them recognise from a professional perspective that social work can sometimes be intrusive in terms of going into people's homes, people's houses. And so in those sorts of situations, this is the important thing, I think, which is where we'll talk about in a little while when we look at the role of technology and what we found from this project as to the role of technology in social work, particularly in the context of adult safeguarding. When you do have a situation that needs minimal support and they've got good family supporting but just can't cope, do we need a face-to-face visit? But again, that proportionality. So what are the requiring a thought of what are the facts and what are the circumstances around this particular situation? So just to move on to the last part then in terms of technology, one of the things that obviously came through very, very strongly was this rapid shift to technology early on in the pandemic. and some of the challenges and changes that this had prompted. In terms of frontline adult safeguarding or social work practice, there was definitely felt that there was a role for technology moving forward. And we're not just talking about virtual ways of working that we might know from our workplace, so Teams, like using now, or Zoom or Skype or anything like that, but also the telephone, WhatsApp, all those different modes of technology that we can use to communicate. And so one of the things that we want to look at more is, in what way can technology be useful, and what can we learn about the way technology can be used moving forward? So first of all, the importance of knowing which technology is most appropriate and most inclusive in any given set of circumstances. And this obviously involves a reflection and consideration of the person that you're supporting as well. This was very often a theme, was identifying that actually in some cases technology can be more supportive than a person or in-person visit. One of the examples given, for example, was when doing a best interest assessment or a capacity assessment with a person with a learning disability who might live in a care home or a residential facility. Actually, in some situations, practitioners found that they were more engaged with technological ways of working or remote assessments than they might have done with a face-to-face assessment previously. And so technology also, as the reflection on the last slide said, technology can be less intrusive in some way. So a telephone call or a Teams call or a WhatsApp call or whatever can be less intrusive for many people. But what was important also for professionals was the adapting and using different questions depending on that mode of technology that you were using, that mode of assessment that you were using. So it gave them an opportunity where they were doing a telephone or a virtual assessment, say if they were doing a capacity assessment, to use informal carers or to use paid carers that go in. Those carers that they might not have ordinarily used or involved as part of the capacity assessment, actually they had to use because they were the person there supporting that individual with their communication. Doing multiple assessments can be easier as well, using remote ways of working or remote ways of assessing. And also other aspects such as using more detailed case notes, or in some instances making use of other technological advances. So for example, for best interest assessors, the remote access to care plans in care homes. I think what was the strongest message, though, that came across from universally across the participants, certainly in the interviews, but I suspect also in the surveys, was having the confidence to know when those sorts of face-to-face visits were still required, while also minimising risk. And again, some of the challenges that came up was minimising risk. If that involves using PPE, then actually it can be difficult. PPE can pose its own difficulties in communication. But I think this quote from this particular participant summarised it very nicely. I think we've got to be very careful that our systems don't become so digital that we forget the value of going out in person. This was the strongest message, really, in terms of technology. So knowing that actually technology is not going to be suitable in many circumstances, and actually social work in particular as a profession depends on that human interaction, and proper support depends on that human interaction. So in terms of creativity, and again, this is one of the dominant themes, the pragmatics of creativity and how professionals had reported being creative during the pandemic. So first of all, thinking about the location. So where it isn't possible to go into a person's home or see them in a care home, for example, are there other locations that could be used in order to maximise that person's participation and to do the face-to-face visit? So for example, going to a park, garden, taking someone to a medical appointment, for example. Taxi services, making use of taxi services where taxi services were still being used. Refuse collection in particular, this was linked very often to cases of staff neglect. So refuse collections can also be useful in terms of eyes on the ground. And also the increase in volunteer and community support groups that we saw during the pandemic. We had a huge drive in 2020, when there was a lot of people furloughed, to increase these volunteer groups and community groups. And so what can we do to maximise their potential now if they're sort of people on the ground or eyes on the ground in terms of adult safeguarding? How can we involve them also in that safeguarding process? And obviously banks, in terms of financial abuse and greater engagement with banks, which can be challenging in itself. I think probably banks don't always necessarily see that they have a role to play in adult safeguarding because of the nature of the type of institution that they are. But there have been some good work reported in terms of relationship between local authorities and local banks. And also creative use of those conditions to mitigate the fact that people weren't always allowed to leave care homes. They didn't have as ready access to the community as they might have done pre-pandemic. So just to end, I want to talk a little bit about professional curiosity, and this came up a lot in the conversations that we had, and it's been there underpinning a lot of what I've talked about today. So professional curiosity is often sort of thought about as being an individual's professional curiosity to get to the bottom of a set of circumstances. And this is how it emerged a lot from the research. And again, this quote summarises the importance, the challenges that COVID has presented to professional curiosity, but also the importance of it in adult safeguarding. But actually what our research found, and parts of the research I haven't talked to you about today, so about workplace cultures and organisational cultures in particular, supporting that professional curiosity, that actually aligns with what professional curiosity is as a concept, in that it doesn't just belong with an individual, it doesn't just rest with the individual social worker or adult safeguarding nurse. It actually exists on an organisational and a strategic level as well, and it's about fostering that environment where a person can feel able to be professionally curious. And I've put a couple of links if anyone's interested in that in the context of adult safeguarding, to a couple of briefings. So the first, the research in practice briefing. This is not connected to our research, but it's about professional curiosity. And this was written by the same people who wrote the article. You do need a subscription to research in practice, I think, to get it. But the article, the Journal of Adult Protection article by Helen Thacker-Anamper and Bridget Penhale, is about professional curiosity. Could curiosity save lives? And about the importance of professional curiosity in adult safeguarding work. So that's it in terms of the substance of the talk. But what I want to do now is just take a little poll, really. And in the chat box, which I've noticed that I do have access to, which I didn't before, or didn't think I did before, has been hidden in a drop-down menu. What I wanted to ask, just really, is for you to put your thoughts in the chat as to what extent these sorts of findings that I've been talking to you a little bit about today, and it is only a small part of the research that we did, mirror your experiences over the past 2 years, really, or 2 and a bit years. So if you feel that they mirror your experiences in your professional area a lot, then put A. B, some, but not all of it, then B, and C, if you don't feel that they've resonated at all with you, then put C. It's just really interesting also for me to get a sense of actually the generalizability of these particular findings. So some Bs, a lot of As. Right. So while you're doing that, I'm going to move just on to the next slide quickly to tell you a little bit about, if you're interested in finding out more about the research, we do have a project website which we're no longer keeping up to date because unfortunately we don't have our research assistant anymore who used to do that for us. We have developed a number of sort of resources for people to go and download if they want. So these the two pictures on this particular slide are the 2 sort of single-page research briefings that we've put together that you can use if you want to find just sort of snippets or you want to disseminate them more widely. You're welcome to do that. There's also copies of our publications, copies of the reports that we've published, and links to more information about the particular project. So do feel free to go and have a look at the website. I've also in the chat box put in a link to the fuller findings, the webinar. We hosted a webinar last November as we were coming to the end of the project with more findings from the research that goes into more detail about all the different aspects. So I'll put a link to that in the chat if anybody wants to go and listen to that. That's on YouTube, and you're welcome to do that. It's quite a lengthy webinar, but it does go into detail about lots of different aspects, whereas obviously I've only talked about 2 or 3 of them today. And then the last thing that I hope you don't mind, but I'm just going to talk to you a little bit about, or just bring to your attention, is a couple of courses that we offer in the School of Law, if anyone's interested. So we do offer an MA in Safeguarding Adults, Law Policy and Practice. I'm the programme director for that. And if anyone's interested in this particular programme, we look at it from an interdisciplinary perspective. So the sessions in the past, and there have been sessions with Susie Gray, for example. We've had sessions with various different guest lecturers that are quite big on a national level. Margaret Flynn has just been to deliver a lecture 2 weeks ago around organisational abuse. And this really is a programme that looks in more detail at the legal framework in particular around adult safeguarding. both in terms of the Mental Capacity Act, so there is an entire module on the MCA, but also more broadly, so the civil offences, the criminal offences that frame adult safeguarding. We also offer a number of the modules also on a standalone basis as Cpd modules. So 2 in particular that we've offered previously, or we're starting to offer this year onwards, the mental capacity module and the safeguarding adults interventions module. So all the modules are taught on a block basis, so as to allow people who come from professional backgrounds and they want to just take 2 or 3 or 4 days off at a time to study a particular module. And there's 4 modules for each particular master's programme, for this particular master's programme. You can study all 4 in 1 year and then the dissertation in your 2nd year, or you can study over a period of up to 5 years, so it can be really flexible in the way that you study it. And again, if anyone's got any questions or wants to have a chat about the modules, even just an informal chat, then feel free to contact me. And also I've got a load of students who are more than happy to talk to you, current students who are more than happy to talk to you if you want more information about what it's like to actually study the course on the ground and the benefits that they've got from the programme. And then the last thing, just to bring to your attention, was hoping to also put together an MA, a new MA in Advanced Social Care Law, which will be a really flexible way of studying at master's level. So first of all, there'll be a general overview module of the principles of social care law, both from an adult and a child perspective. And then there'll be flexibility to choose basically your own degree pathway with a variety of different modules. And we're hoping to put this together and have that approved in the next year or 2. So again, if anyone's got any queries or feedback on this particular model or wants any further information about it when it is, or hopefully when it is approved, then do drop me an email. Again, my email address is on the slide. I'll be more than happy to chat to you. So that's it from me. I'm just going to take the slides down. Has anyone else got any more questions or thoughts or reflections on anything that they want to bring up following our following the research and the presentation? Like I say, if anyone's got any reflections or anything that they want to talk to me about, then feel free to drop me an email. More than happy to, whether it's about one of the courses or you just want more information about the research project, more than happy to do that.
Thank you so much, Nora, for your time and for sharing those really important messages from your research. I know that it looks very much like from the chat that's resonated with people and mirrors their own experiences. So I think it was interesting as well to think about, you know, the messages for sort of future research as well as practice. So thank you. And people are echoing what I'm saying as well in the chat there, and that was interesting and useful. So thank you very much for your time. Thank you. Just to let people know as well that our next seminar is the 9th of September, which is a Friday from 2 till 3:30, and is regarding experiences of children in residential care. So we'll be sending out information about that nearer the time, but just so you can save the date if you've enjoyed this seminar as well. So we can release you all to go back and have some lunch or carry on with your work. But thank you everyone for attending and for contributing and for discussing in the breakout rooms as well. We hope you find it useful. Thanks everyone.
Thank you.
Thank you.
Bye. Bye.